So welcome everyone. So this is an interesting session. We're going to be covering anterior segment, retina and glaucoma, and studying on how the direction of ophthalmic research and practice is moving ahead in a comprehensive manner. The order of today has changed a bit. I think Dr. Kumar Doctor will be speaking first, followed by Dr. Nair, and followed by Dr. Prasanna Venkatesh. So I invite Dr. Kumar Doctor to speak on the future of biometry and anterior segment imaging.
Good afternoon to you all, and thank you, Tosh Bro, for having asked me to participate in this. I'm just going to share a little bit of my experience with this machine, and I'm very glad that I took the right decision, because in today's world we have a huge choice of optical biometers which are there. I already have experience with the Nidec AL scan. I'm already using a lens star. I also have used the Aladdin, and I've also used another Zimmer system. But ultimately, I bought the Anterion. So I would like to thank Dr. Shivani, who's helped me to compile this presentation for you. So I've used all of this. I've used the G6, I've used the IL Master 700, I have used the Nightstar, I also have used the Aladdin. And ultimately, I got concluded that no, this all does not fit me. I can tell you actually what is good and bad with each. And I'm very, very happy that I took the right decision of buying this, because it covers everything. It does an optical biometry, a topography, ASOCT, and imaging. So it's an all-in-one system, and that's what I like about it. So it has a cataract application, an imaging application, a corneal application, and metrics. And all this is really useful to us because we are cataract refractive surgeons. And nowadays, cataract has become a refractive surgery. So we do have patients who are 51, 52, and who do want clear lens extraction. And of course, we also know the advantage of spectral domain versus swap source OCT, and there is no controversy. This is a paper presented by Namrata, and which concludes that it is far superior. The another advantage in this instrument is that number of scans is very, very high and very, very fast, very, very accurate, because it covers a large area. And another advantage I thought was the aiming beam. Now, the aiming beam, the intensity can be increased or decreased depending on the density of the nucleus, and the patient can actually make an effort to fixate. So you really have your visual access, and the measurement is quite accurate. And another way of checking whether the measurement is accurate or not is, again, the advantage is having vertex tracking. So if you are tracking the eye during the measurement and there is a movement, it can also be detected. Again, detailed examination can go as far as corneal analysis, which is now very relevant and important. Anterior chamber depth, lens thickness, and axial length, all information will come to you at the same time. And this can also be confirmed whether you're in the right plane or the wrong plane by looking at the peak at the posterior part. So if your peaks are correct, you know that your measurement is right. So it's a double check on the measurement that is really happening or not. It does measure from 14 to 32 mm. And it can, again, another advantage, whether you have an oil-filled eye or an aphakic eye or whatever you have, the big advantage there is that you can refill the reading. So if you're taken by mistake, your optometrist and made a mistake and done it in phakic mode, you can change it to aphakic mode, you can change it to oil mode. So you can take the measurement and then change it retrospectively. So that's another big advantage. We also know statistically that corneal keratometry results in 27% of the errors in biometry, and the rest is oil misalignment, IOL tint, and angle kappa. So it summarizes that the K reading is very, very important besides the actual length. So I have done a study between multiple instruments, and the actual length matches very well, but the mistake happens in the K reading. And if your K reading is not as accurate as your actual length, your biometry goes haywire, and that's the reason why this has a big advantage, and the need for keratometry is very, very there. Another thing here, it gets you both the readings together, so your right eye and left eye is presented together. Both IL calculations are documented together. You also have a corneal map that is total K reading, and angle kappa shown in the same map. So this all data and information is presented at the same time. Because you have both the biometries together, if there's a big error and difference between the two eyes, you can detect that, because then you can find out whether there's an error in the reading taking or not. Corneal aberrations, very, very important now, because nowadays I'm doing LASIK since 1999, and these patients are coming back with a cataract. To look at corneal aberrations and deciding what kind of IOL you really want is very crucial. And that's why the corneal aberrations, total corneal power, has suddenly become very relevant, and which was not so important 10 years back or 15 years back. Again, white to white, important, you have the universal Barrett suite, and it also has a ray tracing formula there, Oculix, which is also included in the whole package. Enter the toricity, and then you can do the planning, etc., and you can go ahead and do that. So you have your corneal aberrations decided at the same time. You have the anterior surface, posterior surface, total corneal power. All of this is there in one shot. I've gone through all this. I had the Nidec AL scan. If you want, I can tell you what is a flaw with it. I'm right now using the Lenstar and the Anterion, and I still overrule the Anterion with everything. So I've gone through all this. We're also doing a study between Anterion, topography and the Pentacam, and how well does it match or does not match, what is the right decision. So now just give you one example. Take this example, 5 patients. I've taken Anterion K reading, Lenstar K reading, Pentacam K reading, and IOL. And you can see the axis, the toricity, all don't match. So if some of you who have a auto K, and some doctors rely entirely on auto K, how reliable is that? Answer is no. So you can see that 5 examples, everything is different. I decided to just follow Anterion for my study in the initial cases, and believe you me, I was dot on. So I have the data on the last part. All of them have a trifocal toric, and all of them are doing well. So point here is you have to standardize your measurement technique, your measurements, and then decide which instrument you can rely on, and then go ahead and use the same. I think I will show one example of the cases. I'm just going to share my experience. Case number 1, patient came for cataract. So you can see a very shallow anterior chamber to a long eye, a myopic eye, shallow anterior chamber, keratometry. We do 3 formula calculations for everybody. Any IOL, sometimes even 4. So this is a Barrett, and the patient went ahead and had a trifocal with a 23 diopter, and the patient is doing very well. A very shallow anterior chamber, you can see this, a PI done. That's another big advantage. You have the readings, and I did ACDs of 1.92, a small eye, good lens thickness, okay, and a K reading, and white to white, which is small. Again, I did the Hill RBF, the Barrett, and we did all the calculations, and decided to go ahead and implant a 31 diopter with a 3.25 multifocal, and the patient is doing very well. Now post LASIK, this is the common problem that we face. Again here a long eye, ACD, again many formulas, calculations, and you can see here that I'll show a data of multiple things. Like so here I have ACRS calculation, I have ACRS Anterion calculation, so the K reading is fed, I have the IOL master. So I decided to do, sometimes I do one more reading to make sure everything is on track. And yes, I went ahead and followed the Anterion, and this is what I got, is a very good reading of 6x6 part. As far as imaging is concerned, I think it's a brilliant tool. Just for your information, it does everything, right? The front part, back part, the back, those who are using the machine, they already know that it does very well. You can customize which scan do you want, that's another big advantage, and use it for your reading. Just for your information, those who don't know this, this is a lens dislocated with the vitreous coming in the front. Last year at the ACRS, this got the first prize of the OCT category of photography. This year I got the slit lamp prize of photography in the ACRS. I did not win anything in the OCT. As far as keratoconus is concerned, this is another thing you can do: visualization, muscle attachment, eye stent in the eye, you can even see that. That's another big advantage. Wide chamber, shallow chamber, narrow chamber, everything can be seen. Another thing, I had done one patient, I had a Descemet's detachment, I didn't put an IOL. Obviously the thickness of the cornea is going to go up, 666, and you can actually see the Descemet sitting below. So the mistake I made is I did not put an IOL. Because I did not put the IOL, the Descemet went into that cavity. It finds wherever the place is there. And then I went ahead and of course did the gas filling because the air had failed. Went ahead and put an IOL, so you can see the IOL in place, put a gas, and the Descemet gets attached over time. And you can see the air and the gas sitting in the eye. A patient with intacts, again good for imaging. You can plan it and you can know actually the depth of the intacts. These are my patients. And you can even measure. So if you planned it at 450, really is it at 450? That's another big advantage of doing the imaging. Now this is a rare condition, you may not see it very often. It's called posterior lenticonus, again imaged on the OCT, and it does photograph very, very well. Ahmed glaucoma valve, again you can see the valve coming in the anterior chamber, peripheral iridotomy, a very high hyperope, closed angle, and prophylactic PI was done in that case. You can even measure angles. That's the advantage with matrix that is also included in the whole system that goes on. Now, one case rare, even operated in my center, a small nucleus piece suddenly appeared behind the IOL. So if you see this post-op, it's a little tricky because you don't know whether the PC behind was accidentally left by the surgeon, torn, and the so piece was left or what. So this again helps you in imaging because you have the IOL, you have a nucleus sitting behind it, a small piece, and behind that a posterior capsule. So you really know that your posterior capsule is intact and you can still go ahead and just remove it. So you can see the nucleus piece sitting there just behind the IOL. And the PC behind that is intact. Another case which I operated was a posterior polar cataract with a break. So of course now the new femtolasers which we have do have a built-in OCT, so we can detect it. It's not that. The big advantage now we have this system is that you can detect it before the surgery and accordingly plan your surgery. This patient underwent surgery at my place and we put a IOL in the bag without extension of this rent which was pre-existing. So there is a pre-existing dehiscence already there which can be detected. And this is there which is possible. So the big advantage in the femto, you can see that you can plan it, you can move your posterior above the PC far away. So normally it's 600 microns from the PC, but in femto technology you can move it to 1.2 microns away from the PC, and that's one big advantage. Thank you all for your attention. That was for imaging and biometric.
Thank you, Dr. Kumar. Brilliant images. The first part went over our head. We are retinal surgeons. We don't look at IOL power. But the second images were brilliant and beautiful. And congratulations on your wins at the ASC.
Thank you.
Thank you.
Thank you.
Thank you. Any questions from the audience? Okay.
So now we move on. Next talk will be by Dr. Unikrishnan Nair. So he'll be talking about assessing disease progression using multimodal imaging. Dr. Nair.
Good afternoon, and thanks for the kind invitation for this talk. So multimodal imaging as a tool can be considered as many parts, but the whole idea is that the whole is greater than the sum of the parts, and how to use multimodal imaging with, I'll be talking mainly about the Heidelberg system, sequential or simultaneous imaging to create assessment of various parts of retinal diagnosis. Here we'll be looking at MMI exclusively to look at the progression analysis in these 5 conditions and see how it helps. So geographic atrophy, there are many ways to identify geographic atrophy, starting from the multicolor, better delineation than the color fundus photography and infrared, and then you have the fundus autofluorescence and the other modalities, but the favorite modalities for us are the OCT and the OCTA. So just to look at this, you have the picture on the extreme right is a regular color fundus photograph, but when you apply the multi-color, you have exact dimensions of the areas of geographic atrophy, and that is one of the greatest advantages of using different light color sources to identify geographic atrophy. Just coming quickly to autofluorescence. The autofluorescence is based on the principle of the presence of lipofuscin inside the RP, and the absence of lipofuscin is what creates these beautiful images of geographic atrophy. So you can see confluent geographic atrophy at the extreme right, and you can see patchy geographic atrophy. And when it is hyper autofluorescent, those are the RP that is going to go into geographic atrophy. It's a brilliant concept. So the progression of geographic atrophy, RMD, is shown by this very famous group of images from the original study where you see the geographic atrophy increasing in size. And according to the same thing, there are modalities by assessing the hyper autofluorescence, so the brightness around the areas of the darkness, and categorizing into various types. And by this, there's a diffuse banded type which has a rapid progression of geographic atrophy. So I'm going to show you some other images, basically how to predict it happening. These are very interesting concepts. So you have these small hyperreflective areas over the bumps. Those are called HRF, or hyperactive foci. They're kind of the retinal pigment epithelial cells detaching from the PEDs, and that is an indication that atrophy is going to happen. Here you see one of the HRF over the PEDs, and over time you see the PED collapse, and then it results in atrophy. So that's one sign, seeing these hyperreflective foci. You see this in these cases. This is a patient which has nearly 10 years follow-up with us, And over the 10 years, you can see the changes over time, the same patient increasing lipofuscinoid material changing, and over a 10-year gap, it converts to this condition called C-RORA, or retinal and outer RP and outer retinal atrophy. This is a 10-year follow-up. So these are very interesting pictures which show how to predict geographic atrophy happening. You see those lines. Can I have a pointer, please? Pointer. You see these lines, vertical lines. Those are transmission lines of the OCT light going downwards, and that is an indication of imminent atrophy happening. Thank you. Imminent atrophy happening. You see these lines happening. So here, this is again, it's called a transmission tail. Where there is RP atrophy, you see this happening over here. Again, these are multiple transmission tails, and why it is important is gives this diagnosis called nascent geographic atrophy, or geographic atrophy that is about to happen. This is called nascent, where the retinal layers go down and dip over there. So again, the presence of nascent geographic atrophy is a sign that geographic atrophy is going to happen. And going one step further, you have an OCTA diagnosis. See these dark areas, that is choriocapillary dropouts. It happens before the clinical signs or the tomographic signs of geographic atrophy. So now you have OCT signs, you have OCTA signs that geographic atrophy is going to happen. And you can see these images where you have some, and a larger area where you have larger areas of dropout of the choriocapillaris. There are other very interesting risk factors, like the shape of the geographic atrophy. It's called circularity index. The more circular it is, the more likely it is to not progress. And the one which is notched and has different shape, the geographic atrophy progresses. So if you take a geographic atrophy, you make a circle, and you see how much it deviates from the circle, the more deviations, called a high GACI, geometric acircularity index, or a low one. The ones with high progress faster. That is, the more deviation from the circle, it progresses faster. Extrafoveal lesions progress faster than lesions closer to the fovea. The edge closer to the fovea progresses slower. So all these, and this is something called edge characteristics. With the OCT, you have the FAF, you have, this is called a convex hull. You can draw a hexagon around the area of geographic atrophy. The more number of sides and the more larger it is, the faster the progression. You can look at the edge, whether it is a split edge, an irregular edge, and you can assess which edge of the geographic atrophy is going to progress faster. So you have all these various indexes to find out how these are called junctional characteristics, and how the geographic atrophy is going to progress. So let's go to the next condition called pachychoroid. Pachychoroid is when the choroid is thick. Multimodal imaging allows you to image the thick choroidal vessels. You have different conditions like CSR, PPE, neovascularization, and PCV. And this is a beautiful image. Anything green on the multicolor is elevated. So you see elevated is fluid, and it shows fluid here. Multiple modalities to diagnose the same thing. This is an interesting picture. You see green here, you see a little bit of orange here, you see a kind of bumpy thing here, and this is it. You can make out a choroidal vasculature, you can make out a PED, you can make out the amount of SRF also. So this is the beauty. These imaging are depth resolved. You can see the different depths in different colors in multi-color imaging. A cross section will tell you this is a pachychoroid with a thick pachy vessel underneath it. And this is the other thing. You have different layers. Some of the layers are thin. The inner choroid is thin while the outer choroid is thick. Again, in pachychoroid, you have inner choroidal thinning, and that is made out by the OCTA as thinning. A new diagnosis is pachychoroid epithelopathy, where whenever you see a pachy vessel, a thick blood vessel, you have a bump in the choroid above it. And on further examination, I'm just flipping these slides just to show you a few important ones. On further investigation, there are 3 or 4 types of changes. Very interesting. You have a bump which increases over time, or you have a split, a bump with a split. Why is this important? Because now it is thought that these could be the precursors of neovascularization in the future. This neovascularization can go through this micro break in the RP or the retina. And this is how it progresses. You have a small bump and a bump that eventually reaches the external limiting membrane, the progression of PPE. And then you have another diagnosis exclusively now made by OCTA, that is a pachychoroid neovasculopathy. You have all these lesions, a little bit of fluid, a large pachy vessel over there. These 2 are the diagnostic features, having a bump over there and having a network on the OCTA. So multimodal imaging shows you on infrared, shows you on multicolor, shows you on OCT, and confirms with the OCTA. That's the power of the multimodal imaging. So these are again typical features. You have fluid, you have a small bump over there. The bump corresponds to a membrane on the OCTA, and that's how it is used. This is called a FIPED, or a flat irregular PED, which is flat, it's irregular, it goes up and down, and underneath it you will see vascular lesions. So again, we just go to OCTA in PCV. I'm just going to skip these things. In OCT, the new concepts about progression are that there are different types of PCV. PCV is not a common disease, and one of those things you see the branching network underneath the choroid as evidenced by the OCT. There are 3 types. Why is it important? This responds poorly, this responds well, this responds poorly to anti-VEGF. So the progression of treatment can be assessed by this. Going to wet AMD, multimodal imaging shows you this is the typical things we used to do, FFA, but now we can exactly see the vascular network using OCT, a beautiful network of vessels underneath the RP, above the RP in this case, you can see it. And this is how beautiful the image looks, the OCT image of the CNVM looks like. These are other images, and why it is important progression analysis. You have different types of CNVMs based on the OCTA, of which just out of the thing, the Medusa head responds well. Things like this, like the CFAN and the fishnet pattern, do not respond. So your progression analysis is important, that it tells you which sometimes which CNVMs do not respond to anti-VEGF. And this is a good response where all these small vessels are going away. This is a poor anatomical response that after the injection the vasculature is increasing. This is a very important concept regarding progression, the presence of recurrence. It's a very important feature to look at this. The OCTA shows a network around it, small vessels around it, and the first sign of recurrence by OCTA progression analysis, you can make out whether the CNVM is coming back. These are all images in the same line. In this particular image, you see a dry part where it's inactive and an active part, beautifully seen on the OCTA. So I'm just going to skip these, so we just don't do too much over here. Okay. So finally, there are new diagnoses on finally. The new diagnosis, one is called a non-exudative CNVM. There's no signs of exudation, but you see a network on the OCTA. And why is it important to diagnose it? Because you've got to keep on watching this, because in a year, 18% of people go into having a full-fledged CNVM. So that is why these are important to diagnose. So I'm just going to skip all these, just the basic things are required. So in MACTEL, it's a condition where we actually use this a lot. You see the features of MACTEL, you see the pigmentation, you see the changes, and you see the CNVM happening. These are changes. This is what a color photo would tell you, but a multicolor would bring out everything, the pigment, the hemorrhage, everything. It comes out better in a multicolor imaging. And this is when the MACTEL has a hemorrhage inside, and then when you do the OCTA in a patient with proliferative MACTEL, you see a vascular network in the avascular zone, and that is diagnostic. This is the dynamic angiography by which we can make out as the dye goes by, you can see the vascular net coming beautifully at this point of time, and over time the leakage increases, and this is a very key important way of diagnosing MACTEL. So some of the other features of MACTEL is called invasion, where some of the vasculature goes to the lower layers and it has to be differentiated from a CNVM later. So just to summarize, in dry AMD, the fundus autofluorescence and the OCT is important to assess the edge characteristics for assessing the progression. In pachychoroid, knowing the subtypes and how will tell us how they respond to anti-VEGF. In wet AMD, identifying poor response characteristics and recurrences, identifying a non-exudative CNVM, so you catch a CNVM earlier than it has to happen. And in MACTEL also, the diagnosis of choroidal neovascular membranes are essentially with multimodal imaging. Thank you.
Thank you, Dr. Oni. That was a beautiful talk. So I just have a question for you. I think now we are having new therapies for dry macular degeneration, like Syfovre and the complement based. So based on this upcoming exciting new therapy, where do you see the role of autofluorescence, and specifically the difference between blue and green? Because I know Heidelberg has both these features.
See, I'm not sure that, I'm really not sure that autofluorescence is going to be the key, what do you say, the research tool for measuring the progression using these methods. It's a gross method, but the real methods are going to be the edge analysis, that is the ellipsoid edge analysis, the junctional features, and because knowing which edge is going to progress is going to be the most important features, and those are some of the key features. And more than autofluorescence, basically it is going to be QAF, quantitative autofluorescence, which is going to be the biggest tool in the future for dry AMD studies.
And the second thing was, if you just see a network on a octa, like you showed some beautiful, like, would you like to treat that, or would you always look for some fluid or SRF on the B scan, corresponding B scan?
So if it is a patient coming to you for the first time and you see a network and there is no fluid, you do not treat, because it's a pre-clinical, it's a non-exudative CNV. But if it's a patient you've treated who's been quiescent for some time and you see a network, you have to treat it because you know it's going to go to exudation soon. Thank you.
Thank you. Thank you so much.
Thank you.
We now move on. So now we move on to glaucoma, and I invite Dr. Prasanna Venkatesh to speak on this interesting topic.
Thank you. Nice talk, Unni Krishnan sir, and thank you, Dr. Shroff sir, for giving this opportunity. Heidelberg team. First, I would like to thank the Heidelberg team. This talk is a long time due. On November 23rd, I did want to do this talk, but unfortunately, due to unforeseen events, I was not able to do it. I think the whole Heidelberg team know why, but it's like a complete circle for me because I take immense honor and pleasure. What I missed 3 months back, I think I'm here today and looking forward to this. So Anterion, as you all know, Anterion is something that is being marketed for refractive surgeries or for lens or cornea. So this is a totally unexpected thing that I am exploring into glaucoma. So sit back and relax in the next few minutes. I'm going to show you how Anterion has been customized for my glaucoma practice and how I'm going about it. So I would like to thank my mentor as well as Martin Long and Shanaz and the whole Heidelberg team for introducing me. Mr. Venkatesh is there from Trosh Bro. So I'm a MIG surgeon, I'm a glaucoma surgeon, and I'm doing more MIGs. So what happened with Anterion is I started imaging the different kind of MIG surgery that I'm doing. So bent ab interno needle goniectomy. So what is this procedure is, we just bend the needle opposite to capsular axis and we open up the trabecular meshwork. So you can see that with a 26 gauge needle. So what I do is we just open up the trabecular meshwork. So a lot of MIG surgeries are now being the talk of glaucoma town. So how do we evaluate a MIG surgery? Because there is no particular marker and a ASOCT or a UBM is not high resolutive enough to really go about it. But with Anterion, and I'll show you another surgery called KDB. So 26 gauge needle is done for bang. It's called bent ab interno needle goniectomy. And then there you can see a direct gonioscopy here followed by the KDB. So in this we can see the blade is made for this. So it's a dual blade called the Kahook dual blade. So this is upcoming in the glaucoma sector assay. I just wanted to show the procedure for the neophyte so that what we are going to talk on, it's going to make a lot of sense. So this is made for that, and there is another one called the 26 gauge needle, and this is an animation of the same which is done for specialized for this kind of a procedure which is more refined. It ramps up the trabecular meshwork. So what I have seen in Anterion is, so this is post KDB and this is post bang. I wanted to evaluate the angle structures because in KDB what I started observing in the gonioscopic findings are the leaflets, the trabecular meshwork leaflets were very minimal compared to the bang. So you can see that in this Anterion picture, we are now publishing this in the next issue in IJO. Yeah, if there is a pointer, it will be very nice. Can I have the pointer, AV team? Yeah. So you can see this W sign on the red arrow here. So this is a complete excision of the trabecular meshwork, and yeah. Thank you. So this doesn't happen with the bang. So this KDB gives you a complete Y sign which we are publishing in the next issue. Whereas with bang you can see the 26 gauge needle is not made for it. So what happens when you use a needle and open up the trabecular meshwork? There are some leaflets here and there like a curtain remnants. So that gives you a remnant. So this is one imaging device is actually imaging the trabecular meshwork. This by trial and error we have got it done, and we are now publishing this. You can see this remnant here. This serves as a precursor for a peripheral anterior synechiae or even trabecular meshwork to actually again close back. So let us see other MIG surgeries like G1, right? iStent and iStent inject. So these are something that are being spoken highly about in the market. I need the cursor also. I'll be forwarding my video. Yeah, I'll not be able to forward the video. Cursor is fine. So this is a G1, iStent G1, where you can see that the tangentially the stent is placed. The stent location, because if it is not working, why it is working. Trabeculectomy, we do know how it functions the way it functions. But mix is something which is very much new, and we have to really know how things are. So we do have some visual markers like the vessel getting perfused in the episcleral vessels that you can see here, which is getting perfused as I place the stent. But iStent, you can see that this is a 1 year follow-up patient. It helps you not only along with gonioscopy, there is a back shadowing, especially in that particular plane where in the exact pigmented trabecular meshwork that you do. Again for G2, generation 2 series, not one but we place 2 stents, right? So it's an axial injection where you place 2 stents on 2 clock hours apart. Of course you get a visual marker of a paralimbal blanching, a white area appears as you place the stents in the right plane. Again you can see beautiful 2 stents, Antirion evaluates it, whether it's in the exact plane of choice that you want to. If the IOP is still high, we can always go back. Then comes suture gat. Suture gat is one technique which happens with a 5-0 Prolin suture. It is a very cost effective mix and which is being highly recommended by all the mix surgeons for drop in intraocular pressure. What you do is you just make a nick in the MVR blade in the posterior or the pigmented trabecular meshwork, and then what you do is you pass a 5-0 Prolin suture, make the mushroom a tip into it, a 24-25 throws, and what happens is this comes out the other side, just like a donut, right? You keep on passing and it comes through the other side. You can see that now the suture has come 360 degree the other side. So we don't really have any particular modalities to evaluate the Schlem's canal, the trabecular meshwork, because mix is the happening, hot and happening in glaucoma. So what Antirion gives you, it gives you a bird beak configuration. You can see 360 degree the Antirion imaging was done, and there is a bird beak configuration. So with the bird beak configuration, what happens is, it's like tearing a paper. If you tear a paper with a thread, always the paper can again go back and join with each other. But with KDB you saw the Y sign, completely the trabecular meshwork was scooped away. So this was our observation and publishing soon in IJO. So I wanted to start with mix because this is something which is very, very important, and I think Antirion helped me a lot. No financial disclosure here, I do have the machine, but this is something I feel any anterior segment surgeons who is doing mix, you should evaluate it and see how your angles are, because your ASOCT and UBM will not give you this resolution. What Antirion is giving, I feel you can even go one step further and evaluate the Schlem's canal as well, which we are actually doing. Of course, lens has a role. Whenever you remove the lens, the chamber deepens. So as a glaucomatologist, always that is more important to me. This pinch region or the iris lens channel, right? This is the region that pupillary block happens. So I need a lot to work in this region, study what happens in this region. Now I'm shifting from this area to this area. So this pinch region evaluation, how it really happens, the iris lens channel, because ultimately we do AIOC because we don't want the pupillary block to happen. So we make an opening for this particular patient. So Antirion before and after, we started imaging patients how AIOC eyes are. So I'll just show you, I'll skip the procedure, we all know the procedure. So before and after LPA, you can see immediately taken there are a lot of pigment dispersion, but you can see the opening here, and you can definitely see the angles that are opening up. You can see how in the age here before and after, again another patient, see you can see the angles here. I have made a PI here, you can see how much the angles are actually opening up. You can see how narrowed the angle recess is here, but this angle recess, despite the lens being, you can see how it has opened up. So Antirion is giving more light to these structures as well. Of course, if you are doing a cataract extraction, definitely the iris will fall back, definitely the ciliary body will also fall back. These are our own animations. Definitely the scleral spur is also falling back. We are able to see this in Antirion as well. The breakage of a peripheral anterior synechiae for that matter. Again, this is a very important real-time scenario which I wanted to share. This is one of my cases of combined surgery. I started the surgery, things were all going as per plan, but then the surgery got complicated. You can see that there was an iris prolapse, corneal edema, one of my earlier cases, where there was a PC rent, which I managed very effectively. You can see that the rent has happened, but then the cornea also was very cloudy, but that's not the point here. The surgery was managed, the antivitrectomy was done, and all's well ends well. It was a clean case, and finally the lens was placed in the bag. You can see this is me placing the lens in the bag. The PC rent was very small, and then it all's well ends well. I was able to complete the surgery, but Antirion gave me an idea that how can I go back and evaluate this patient for long-term lens stability, right? So this you can see that this is an eccentric PC rent. So I went back to my drawing board in this patient once the surgery was done. of course, at the end, there was some completion that I had to do for the trabeculectomy. Now the patient is 24-month review. So this is an undilated one, and then you can see this is a bleb, all is fine, the patient is happy, 10 millimeters of mercury. So what you can see here, the PC rent that happened, I am still able to monitor it at a quantifiable level. So the lens stability, it was a monofocal, but if I had chosen a toric lens for this particular patient, you can see that the PC is also very much where the PC is decent. When I dilate the patient now, even that can be evaluated. I think these are things which are very promising. You can see the slit lamp image of the same particular patient. And then not only that, we have done many publications with the spectralis anterior segment imaging module and anterion for that matter, which I would like to share. This is an axonal Rieger syndrome who had an incidental coloboma. You can see that even the posterior embryo toxon can be done the attachment that happens, right? Because when you see pediatric babies tomorrow, angle dysgenesis is a very important topic that we need to really get a hang of. Actually, the angles are okay, but the posterior embryo toxon is preventing you from doing a gonioscopy, and in gonioscopy you won't be able to see it, but with anterion you can bypass it and you can actually see these things. And again, this is a completion of the same, where there's a patient and an incidental coloboma along with it. And this is one of my cases I presented in Rome, Italy last year in the World Glaucoma Congress. So this particular patient presented to us after he was done ICL elsewhere, and he was not happy because he developed epithelial edema and he was advised ICL explantation, and obviously he's not very happy. So when he came to us, a simple examination of ICL mapping, like you can go ahead, get your imaging done, see whether the ICL vaulting is perfect or not. You can see that the ICL vaulting was perfect. There was no issues with the ICL, so we went ahead and did a trabeculectomy because the gonioscopy was more pigmented, and the re-diagnosis which was done as angle closure elsewhere, we diagnosed it as open angle, and the treatment was a simple trabeculectomy with Ologen, and the patient is now on 5-year follow-up and is very happy. We did have the anterior segment imaging module back, not the anterior at that time, and you can see the follow-up pictures, the patent ostium and the healthy functional bleb, and the patient is very happy. Again, another case which really helped me with anterior was this particular patient. We were using a lot of bleb Ologens. Patient presented to us 3rd month, 6th month or after a year with a discolored Ologen bleb. So as a glaucomatologist, we were very confused, like what are we seeing? Whether is the sclera thinning or is something happening in this particular area? We were able to identify that the Ologen implants of one particular batch had a side effect that after a combined surgery with the intracameral antibiotic that we were using, it became discolored, where you can see that this is a discolored Ologen bleb that we were able to image with an anterior. So we went ahead and published that as well. And this is one which I was lucky to be part of, the Uncharted Eye, which we launched at Mumbai in August 29th, I believe. The nucleus sclerotic cataract, or even the posterior capsule, you can see the edge. This was one of my images where it really helps you in pre-planning. Hydrodissection or hydrodelineation, many a time we end up doing it wrong and we end up with a complication. And this is again one of my publications of a Urates Zavalia syndrome, because after an eye stent placement, again these are images from that where you can see that we have imaged it, and anterior really helped us to understand how it happened the way it happened. The implant was slightly not the place where we wanted to, and also there was other findings like a a pigment dispersion. It was more a pigmented angle, as well as there were many studies where an IOP spike can actually cause a Urates Zavalia syndrome. But this gives you a complete holistic evaluation of one particular gray area, which is of high resolution, which is what I would like to put it. And then you can see we are doing extensive anterior segment artificial intelligence studies with anterior. I would like to show the schematic plan of our original study, which is due for publication. This is the image that we started with ultrasound, because ultrasound biometry as a glaucomatologist, that is what we always start with ultrasound, UBM. So we started mapping the trabecular meshwork and the scleral spur. Then we innovated a protractor here, as you can see. This is a novel protractor that we made where the image can automatically detect whether it's open angle or not, along with the angle. You can see this is an AI protractor that we are trying to make. With UBM is what we started. Then we went to Anterion, and you can see that we are working extensively with, the company people can correct me if I am wrong. As of now, I don't see a protractor which gives extensive anterior segment grading. So we are working on that, and along with that, we are planning to extensively evolve into other parameters which are very important for glaucoma as well. Again, this is the same template that I showed in the UBM. We are training the machines on how to pick up the trabecular meshwork, how to pick up the scleral spur, because for mix going forward, these are very important areas we need to understand so that we can get the Schlems canal imaged and go forward. And yeah, spectralis anterior segment module is another one which is also useful, which we are working there as well, along with sheen plug imaging. We annotate the machine, and then with this algorithm, the machine will able to detect all these indices, whether it's angle closure or open angle, scleral spur, angle recess and whatnot. Unlocking potentials. So these are some of the very eccentric images that I started collecting. I don't know why I started collecting, but I just thought I'll share it quickly as a part of the ending. See, microcystic corneal edema. So these are some things which I have never seen any machine give me these things. Anterior capsular phimosis, can see in an extensive level, anterior dislocation of lens in anterior chamber. This is an award-winning image in ASCRS this year in Boston. I just got the image the news 2 days back. So I think these are some things which is very fascinating. Adherent leukoma with anterior synechiae. I still don't know what is the clinical implication, but these all look very eye candy. An aphakic patient with silicone oil, a bleb, one of my patients, again with endocyridectomy, BCL in situ. You can see the fine BCL in situ. You can see the posterior synechiae in a uveitic patient, posterior synechiae in a patient with IOL, ICL vaulting, which I already covered, whether it's a good ICL vaulting or a poor ICL vaulting. And we have extensively published all our images in our regional journal, be it evaluation of a nevus, be it a staphyloma that we are evaluating. I think we have to think beyond cataract, beyond cornea, and we also started innovating with our holograms. People who know that we are doing a lot of HoloLens innovations as well. We are trying to incorporate the anterior images for anterior segment imaging. With the headsets that we have slowly but steadily started to make evolution into the anterior segment imaging, so that not only posterior segment that retina and OCT gives you, we need to go into anterior segments as well. And as a glaucomatologist, my area is more of that. But obviously, as Unni sir covered, definitely all modalities, all multimodal imaging can be worked with it. And this is again another data of mine. We had a phenytoin induced bilateral angular attack closure patient. Again, you can see the imaging, it gives you extensive before and after AIOC2024. See the amount of opening that you can really appreciate. This is sheen plug imaging. In sheen plug imaging, you can't appreciate it that great, but with Anterion, I think the image speaks for itself. We went ahead and published this as well. There are again many publications of mine which I'd like to share. You can see that this is one of the vitreous bulge that happens. Why Anterion again? See, I was very confused whether the vitreous was actually touching this patient or not. If she was a rural patient, an 80-year-old woman from a village, she was actually seeing well. Whether I need to really go in and operate, because the vitreous was in constant touch with the cornea, I need to make a decision whether I can just leave her or whether I can just go ahead and just do an anti-vitrectomy so that it doesn't touch. See the resolution that you get, right? If you zoom this picture even further, you can see that it's actually very close but actually not touching. So then finally we didn't do anything for her, keeping in age and the compliance and the other part of it. Again, you can see the bleb morphology, how much you can actually dissect the bleb and see, because clinical imaging is one, but see how the MMC bleb which fails, no, this is a ticking time bomb. We glaucomatologists call it a ticking time bomb. It's a white bleb. After 20-25 years after MMC, the bleb gets thinned out. You can see how ASOCT and sheen plug imaging gives the ticking time bomb. So these are something which are not explored, and we are going the maximum. And Iris Bombay, this is again a patient who had a superior tunnel SACS. One of the residents performed it. The tunnel was not stable. You can see how this is a pseudo bleb. See how the loci of the bleb are. There are two loci and a septae. A septae of the conjunctiva goes and attaches it inside. There is so much to explore, my dear friends, with anterior segment imaging. I think we need to explore and dive into more. I just wanted to share some of, this is again one of my microspirophakic patients. You can see how the lens is coming and touching it. I'll just rush through the slides. Again, this is a cough syrup induced bilateral acute angle closure attack in a predisposed hypermetropic patients. You can see before and after AIOC2024 what happened, and then the patient was treated well. And again, last scenario, in the lockdown, we were not able to get corneas. We were not able to get eyes. That time, what happened is we were doing patients who had to be taken for trabeculectomy. We were doing a novel technique of using E-polytetrapolyurethane. It's nothing but it's called Gore-Tex. So whenever the patients had a overfiltration, we were using Gore-Tex and then we were tapping it, because ours is a teaching institute. The teaching never stopped. So we were using Gore-Tex, and then we evaluated whether that tissue is actually enough to hold the conjunctiva. But when we studied and when we evaluated, you can see that there was thinning that was happening, and there was a fistula here, meaning that the surgeon, when there was an iatrogenic entry, we tried to use Gore-Tex to arrest the fistula, but it was not working. So because we were not able to get scleral patches, we were not able to get corneas. This is in the first lockdown that I am speaking. So we did have Gore-Tex, and we were able to at least see where we are or what we are. and you can see that this is again now the patient. Recently we are following up the patient very closely. The fistula, we did think of a fistulectomy, but we didn't do it because when the patient came priorly, this was a fistula. We didn't do a close monitoring, but see how the fistula has become now. With anterior segment imaging, we are seeing the fibrosis. The fistula was like this, now it is undergoing a fibrosis, so I don't want to touch it. So these are some of the images that I wanted to share because I wanted to throw a different perspective on anterior segment imaging. The machine is beyond retina, beyond the optic disc. I think anterior segment, blebs, conjunctiva, sclera, I think there are so much more to explore. This is just some of my observations which I ended up publishing in different journals. So thank you once again Heidelberg team for taking care of me when I had an emergency November 23rd, and I am up and running now, and I am happy that the talk which was long time due, it had to happen at AIOC Kolkata, and thank you once again for the opportunity.
Thank you. That was a brilliant gamut of beautiful images and innovation. I just have one question.
Yes,
You
sir.
spoke about MIGS and how Anterion has helped you with MIGS.
Yes, sir.
So have you ever had to do a redo surgery in MIGS and based your redo based on the imaging on Anterion?
So after I do a mixed procedure, clinically if the IOP is under control, I am very happy. I don't go and over explore. Only if the IOP is not controlled, because I am taking a mild or a moderate case along with a phaco. I do a phaco and then a mix. When the IOP is not under control, then I need a non-contact modality because immediate post-op gonioscopy is not going to be done. I do an Anterion. If Anterion is saying that there is something, some kind of trabecular meshwork that is remnant, some kind of thing that is happening, that could be the cause, and at least I can start the patient on a medication. Then maybe, or if the patient is able to understand, then I can go for another surgery. For example, I have placed a G1 stent. I have not done an excision of trabecular meshwork. In 1 week, I am able to see that the patient is not going to improve with one single stent. Then I tell the patient, see, your eye, I did think that the stent was enough, but it seems that I need to open up the trabecular meshwork on the left and right of it as well. It's called combined mixer. We are coming out with papers on that also. So it's just like taking the patient for a toric IOL rotation, which happens, right? Maybe if it's not in the proper place, we take him up in a week or so. So I tell that, and maybe we take him and we can do an extensive additional mix surgery. Or if you think primarily the patient needs 2 procedures, a combined mix surgery, you can do that way also. Yeah.
Thank you so much,
Yeah,
and
thank
wish
you,
you
sir.
all the best for the SFO session. I
Yeah,
think.
thank you, sir. Thank you.
So I'd like to thank all the speakers and Tosh Bro for sponsoring the session. And any last word? Okay. Thank you so much.